Whenever I'm about to discuss induction with a couple, I feel as if I have to mutter it under my breath as not to offend anyone. It seems to me that everyone who comes into clinic knows at least one person who had a terrible experience with induction. Today I'm going to talk about induction of labour, how it's done, and what to expect. Induction of labour is a common practice in many maternity units, with about 1 in 5 labours being induced in the UK. There are many reasons why induction is being offered by an obstetrician or midwife. It could be that the baby isn't growing to their full potential and it is more sensible for us to look after them outside of the womb. Conversely, it could be that the baby is predicted to be big. Maybe there is an increased risk of stillbirth beyond a certain gestation which we wish to avoid. For instance, when the pregnancy has gone way beyond the due date, or an IVF pregnancy, or for mothers who are older. There could also be reasons for us to induce because we worry that the mum's health could deteriorate. Or there could be no medical reasons but a maternal preference. Ultimately, it's important for you to understand why induction is being offered and whether it's something that is right for you. And I encourage you to question your healthcare provider if you're ever in doubt. So what is induction? All it means is getting labour started one way or another, and there are various natural methods of inducing which you may have heard of from your friends or family. Typically, I would explain induction as an insurance policy for when labour doesn't occur spontaneously. However, we wish for the pregnancy to be completed by a certain gestation, and I usually break the process down into 2 parts. What happens in order for us to break the waters, and what happens once the waters have been broken. To rupture the membranes, the neck of the womb has to be favourable enough for us to pass a tiny hook through it. That means it has to be a little bit dilated, shortened in length, and soft, and that the baby's head is somewhat engaged in the pelvis. There are 2 ripening methods which we can use. Mechanical ripening relies on tools to help stretch the cervix, and there are 2 devices which we commonly use for this method. First is a catheter with a balloon that sits within the neck of the womb, and then there is dilator. These are rods which are inert and absorb the fluid around the neck of the womb and swell like a sponge and keep the cervix stretched. Anytime after 12 to 24 hours, these devices are removed and we assess as to whether we are able to rupture the membranes. The other method we use to ripen the cervix is pharmacologically. They are either gels, pessaries or tablets which are inserted into the tip of the vagina, and they all contain an ingredient called prostaglandin. Prostaglandins are also naturally released around the cervix, which many things help start the labour process. These pessaries are applied between every 6 to 24 hours until the membranes can be ruptured. Depending on your hospital policy, this part of the induction can take place either on the antenatal ward or at home, so it's important for you to ask your healthcare providers to see which setting is most appropriate for you. How we decide which devices start the induction depends on your preference, its availability in the unit, and which method is safer depending on your clinical picture. For example, if you've had a previous cesarean section, the mechanical method is usually the preferred choice. Although the main aim of the pessaries is to help ripen the cervix, it can sometimes cause regular tightenings or contractions, which can be uncomfortable. The duration of this process is often unpredictable, with some being ready after 24 hours and others reaching favourability after several days. Occasionally, the water may break during the process of induction, and if you suspect this has happened to you, you should call your healthcare providers. And sometimes your cervix may already be favourable and we can forego this process of induction and move on to the next part. So once we are able to rupture the membranes, you will be greeted at the delivery suite. We break the waters and wait between 2 to 4 hours to see whether contractions begin and whether we're making good progress. If not, then we consider starting the hormone drip. The hormone is called oxytocin, which is also released naturally to help the womb contract regularly. We will start the hormone drip at the lowest dose and gradually build it up so that we're getting 4 contractions every 10 minutes. We then perform regular vaginal examinations to ensure that this labour is progressing nicely. Whilst on the drip, we recommend continuous monitoring of baby's heartbeat so we can see how the little one is coping with labour. I get questions as to whether women are allowed to move whilst being on the drip and whether water birth is still a possibility. Ultimately, maternity units will have different policies, and it's best that you ask your team as to what is possible whilst you are in labour, and make sure that you're comfortable with the plan before proceeding. I often encourage women to move about as much as they can during labour because it is natural during childbirth. However, if we're unable to monitor baby's heartbeat properly, we may need to change the plan. Like anything in medicine, and indeed in life, there are risks. The commonest issue with being on the drip is that the contractions you feel may be stronger compared to someone who isn't on it. And there are many different options which we can use, including an epidural, to keep you comfortable. Induction of labour may also increase the chance of you needing help in order to achieve vaginal birth, and this comes in the form of either forceps or a vacuum cup. Less frequently, the womb may rupture during labour with the drip. However, this is more pertinent for women who have had a previous cesarean section. There is a lot of debate as to whether women who are being induced have a higher chance of needing an emergency cesarean section. The current evidence in scientific literature suggests Probably not. So that's my 2 pence about induction of labour. Ultimately, deciding whether to proceed with induction and when to do so is a very personal decision, and we are here to help you make the best choice for yourself. If you found this helpful, please click the like button and share this with someone whom you think will benefit from this content, and subscribe to the channel. I'd love to hear your experience, so please leave a comment below, and I'll see you next time.